All right, guys, we will get started. We have time, and hopefully we'll offer some discussion on what hopes to be a lively topic. It's a real pleasure to introduce Scott Egner, who is a long-time friend of our programs and mine, some roots in San Francisco. In typical modest fashion, he insists on just being introduced as a urologist from Chicago, but you can look him up on the web and find all of his plaudits and honors and titles. And his talk today is one that he feels very passionately about. He and I have worked on quite a bit together. We have a real sense, I think this is the right side of history. And without further ado, I'll get going. Like I said, I really hope we'll have some discussion afterward.
Thanks for getting up and coming out, and those of you on Zoom. It's a real treat to be here for a gazillion reasons. This place just oozes with talent, from top to bottom, and it's in my mind, it's one of the meccas of urology, and certainly with prostate cancer specifically. And there's a ton of longtime friends and just wonderful people at this place. So it's a treat to throw this topic out at you. The evolution of this is, I would tell you, a little bit more than 10 years ago, this journey started, and I started to wonder whether what we call grade group 1 now should really be called a cancer, but I would only kind of whisper it to friends after a couple of beers and kind of sheepishly. And then slowly but surely over time, and we started doing some projects and working on it. Now, Dr. Kupperberg and I and many others are shouting it from the rooftops. We've even roped in people like Avery, and I want to push this out there. It's a conversation. There's a lot of smart people that agree with us. There's a lot of smart people who disagree with us. But from moment one, all we really said is this is an important conversation that our community should be having. And so I hope there'll be some discussion, and frankly, I hope there'll be some disagreement and some pushback, because that's an important part of this. These are my disclosures, and I usually let them sit up there so they can marinate and you can go through them. And I love doing trials, and I've worked with companies, and I've been involved with guidelines. None of these are mentioned in this talk. And probably the most important disclosure is that if this dream ever comes true, the name change would adversely impact my practice volume and my income. So I'm kind of working against myself in that regard, but I do think this is the right thing, and Matt said it best. It's the right side of history. I know for some of you, prostate cancer is a dreadful topic, and I appreciate you still being here, even though you have close to zero interest in it. To spice it up, it bums me out that my friend and fellow Chicagoan Ben Breyer is not here. And I did a little, investigative work, and it's interesting. So Ben and I have had long talks about Chicago, and he grew up on the south side of Chicago, and he went to the same school that my kids go to. And through some investigative work and the yearbook coordinator at the school, I tracked some good old Ben Breyer. So for those of you that hate prostate cancer, I am going to sprinkle in some Ben Breyer pictures and stories throughout, so it's worth staying awake. So what's the rationale of this? So admittedly, we've come a long way with prostate cancer and trying to minimize overdiagnosis and overtreatment, but we still have a really long way to go. And part of that progress has emanated from UCSF and Dr. Carroll and Kupperberg and the whole crew here who have done wonderful work. But I would still posit that it's extraordinarily expensive, unnecessary, and tortures literally millions of men worldwide with this diagnosis of what we think is kind of a non-cancer. So the hypothesis is that public health would improve if we just changed the name and took the cancer label away from it. This is the crux of it, as many of you know. As Dr. Kupperberg taught me, and I steal his line, grade group 1 is kind of a fact of aging. You grow old enough, you're going to have grade group 1 in your prostate. And these are autopsy studies, and more than half of men, when they get older, have some microscopic evidence of prostate cancer. And in one slide, this is kind of the clinical reality of grade group 1. We did a study with our friends at Northwestern back in the day where we did a ton of prostatectomies on people with grade group 1. And on final path, 2,500 men had grade group 1. And we asked the question, what's the likelihood of it getting outside the lining of the prostate? It was 0.28%. There was not a single case of it going to the seminal vesicles. There's a separate study by Jonathan Epstein where there were 14,000 men. They couldn't find a single man where Gleason 6 had gone to the local lymph nodes. There was a study from 5 centers where there were 12,000 men where the final path was grade group 1. We know they've had that grade group 1 for years or decades, and still there was basically a never event at 15 years follow-up of a metastasis or death, meaning they'd had it for years or decades and it never escaped the prostate that it eventually caused a problem. And so until someone proves me otherwise, I'm gonna stand and tell everybody, I'm not aware of a single man in the history of time who's ever had symptoms, metastasis, or a death from pure grade group 1, meaning only grade group 1. And so the name of an entity should reflect its clinical behavior. We hear this a lot, these N of 1 or this one time in band camp stories where there are, case reports of people with metastasis that have clonal relationships to grade group 1. This is one of them, probably the best known one. This is the whole mount. I'll take you to that little pinhead of a red dot is the grade group 1. And that is sitting in a sea of high grade cancer. And that is a totally different scenario than what we're putting forth or the typical patient we're talking about. This is a beautifully done study by the Martini Clinic in Germany where they looked at outcomes after surgery for folks with pattern 4. The highest line there is if you had grade group 1. It's basically a never event if you recur, and if you do, it's some local cells, and as I showed you, it never metastasizes. But beautifully and incrementally, it's all about the amount of pattern 4. And so if I had to blow up the Gleason system, I would eliminate pattern 3, and every biopsy report and every prostatectomy report would just quantify the amount of pattern 4 and pattern 5, because that's what matters prognostically and for our decision making. This is the paper I told you about earlier. It was 5 big centers that combined all their prostatectomy data. 11,000 men had grade group 1 at final path, which is horrifying through the modern lens, but that's the way things happen. And it was basically a never event, that 15 years later, having a meaningful clinical event from their cancer. So I would argue if the cure rate following treatment for a cancer approaches 100%, there's a 100% chance we need to rethink everything, including the name of it. This is an old argument, okay? I looked back and Oliver Sartor, who's a well-known medical oncologist, first put it out there 18 years ago in a relatively obscure journal, didn't really push it forward. 2 very powerful groups from Johns Hopkins and the University College of London about 12 years ago pushed it out, but didn't really kind of carry the flag. They just kind of published it and let it die its death. There are a group of us now, multi-D group, and Dr. Cooperberg's one of them. We're the 2 urologists on this paper, but we've pushed it out there and feel really strongly about it, and we're not letting go. And thankfully, there's a lot of projects, there's a lot of other people that are agreeing and writing about it, and we're forcing the conversation. And it obviously resonated. This paper, published in 2022 in the Journal of Clinical Oncology, has been downloaded over 25,000 times. And in the history of JCO, in the social media era, it has the 2nd highest altmetric score. So obviously, it's striking a chord with some people, and we're happy about that. If you just take a step back and go to simple layperson definitions from the dictionary and look at benign versus cancer, based on what I just told you and what you know about grade group 1, it's a no-brainer. I mean, it cannot have unlimited growth, invade locally, and metastasize. So it should, have a label. So speaking of definitions, this is good on so many levels. But really impressively, he had a lot of different activities that you're going to learn about through this talk. So he was nominated for the Illinois High School Journalist of the Year because he was one of the editors-in-chief of the newspaper. He had a rock band, which has such a glorious name, called Wonder Bread. And he was in the chamber choir, hip-hop dancing, a true Renaissance man. We've done this before. So we've done this in thyroid, we've done it in cervical, and most people don't realize we've done it 3 times before in urologic cancers where we've taken away the cancer label. Gleason 2 through 5 vanished once they had a stain for basal cells. pun lump in bladder cancer used to be called a cancer. More recently and obscurely, clear cell papillary in kidney lost its cancer label, and it's now just considered a tumor. Now, obviously, the impact is much greater for grade group 1, but this path has been tread before. It's not new. I'm going to skip over this one in prostate cancer. This is work that's come out of here in Dr. Cooperberg, and it's really important, and it's chilling. So even though we've known for 10 to 15 years the outcome of active surveillance, and I've been doing it for 15 years in nearly every patient that has grade group 1, across our country, 40% of men with grade group 1 are still undergoing treatment. And to me, that's really depressing. And it's just been an incremental change. It hasn't been dramatic frame shifts. We did a survey of 1,300 prostate cancer specialists from around the world, and they came from different backgrounds, and we asked them about a potential name change. We were encouraged that nearly 40% thought it was a good idea. Further encouraged that 30% were kind of in the middle ground and willing to consider it. Not surprisingly, the things that predicted the most enthusiasm were clinicians versus pathologists, because they see the downstream effects, younger folks, people who had more prostate cancer heavy practices, and not surprisingly, on the flip side, the two things that predicted not being happy with a name change were older folks and pathologists. So a lot of pathologists have been writing how this is a terrible idea, and a lot of it is, looks like cancer under the microscope, must be cancer. We all get victimized by status quo bias and not wanting to change things. So I totally get that, but we are making headway. I'm encouraged, I tend to be more of a, cup half full kind of guy. I'm encouraged that 39% of pathologists that we polled support it or were kind of in that middle ground willing to consider it. And then I'm really happy to say there are 4 very prominent pathologists, including Dr. Simcoe from here, who wrote a paper last year basically advocating for the consideration of a name change. And I just pulled a bunch of quotes. The intended goal is to reduce harm. We shouldn't be calling it a cancer based on a sampling bias and the potential for unsampled higher grade cancers. Coming up with some non-committal term or pre-cancer or something. These patients will still be followed. Dropping the word carcinoma has huge impact. And thankfully, these pathologists, promoted a multi-D discussion on it. And to their credit, they say if we don't address this epidemic of overdiagnosis and overtreatment is going to continue. And again, we've come a long way, but we have a long way to go, in our opinion. And thankfully, after we've pushed this out there, this debate has continued. And that's really what we wanted, is just a conversation. And as I said, there's some very smart, thoughtful people who disagree, and that's good and healthy. But in journals, in North America, in Europe, in Australia, we've seen discussions now on the pros and cons of this. Getting back to our, favorite person here, you've learned about his musical side and journalism side. He was also quite the athlete, and there's a lot to unpack in these pictures. There's the cross-country team that by my count has 13 people on it, but 3 people showed up for the picture. There's the baseball team that 5 people showed up for the picture, and then the JV basketball team. And it's Dr. Breyer in action. He was obviously quite athletic. And the question that I would ask him, and I will ask him, is all these pictures were either taken on the same day, or he wore the same thing to school every day for a long time. So if a name change were to ever occur, frankly, from my vantage point, it doesn't really matter to me what it is as long as it doesn't have cancer or carcinoma. All sorts of people have pushed, possibilities out there. We kind of polled the people in that survey. The one at the bottom in bold is the one put out by those pathologists in the paper, an acinar neoplasm of low malignant potential. And nomenclature matters, not surprisingly. So this is a study by Laura Esserman, who I hope most of you know. She's iconic and legendary here in the breast cancer world, and we've partnered up, and she's taken an interest in this space as well. But they did a study 10 years ago on what terms would lead to people's management decisions for early stage breast cancer. And there are a lot of analogies between DCIS of the breast, particularly low grade, and grade group 1. But not surprisingly, if you start calling it a lesion or abnormal cells rather than a non-invasive cancer, people are way more likely to do monitoring rather than over-aggressive and potentially unnecessary treatment. And interestingly and analogous, Alejandro Berlin, who's at the University of Toronto, a very prominent radiation oncologist, did a similar study in prostate cancer. And it was a discrete choice experiment of over 1,200 people with grade group 1, their partners or healthy men or people with prostates, and asked them all sorts of different scenarios. And basically said, based on what you know of this grade group 1 entity, here are different names. And it was actually kind of randomized in there. And it was a very elegantly done and somewhat complex study that was published in JNCI. I'll just take you to this main message. The flat line at the bottom is kind of the baseline of calling it cancer. And every group of men in every scenario, you know, they were more enthusiastic about a name that didn't have the cancer label in it. So if you go to patients, their partners, and healthy men, they seem to be interested in it as well. And not surprisingly, they're more likely to adopt a surveillance or screening, ongoing screening strategy if it doesn't have that nasty C word in it. So my dream for grade group 1 and a lot of other folks' dreams, you know, in this room and elsewhere, is just to acknowledge the evolution that we're trying not to diagnose it anyways. Anyone who's an advocate of screening would say the main goal of screening is to try to find grade group 2 or higher and then make some smart decisions on what to do about it. Every single secondary biomarker that's out there, kind of post-PSA biomarker, very appropriately and justifiably diagnoses fewer men with grade group 1. And they market it that way, and they should. So there's a whole slew of those. There's a half a dozen of them, if not more. And same with MRI. One of the wonderful qualities of MRI is that it does not routinely visualize grade group 1. And we all celebrate that. And we're just putting another thing out there. If we're trying not to diagnose it, when we do, can we maybe give it a different name or at least consider it? And the irony of it is, even if there was a name change, the follow-up could be eerily similar. You tailor it and individualize it, but you still have all your tools available, you know, with your biomarkers, your imaging and biopsy to try to find the grade group 2 or higher. And we have in our clinics a slew of men who are already in that scenario, have grade group 2 somewhere in their prostate, negative biopsies, high-grade PIN, men on surveillance, and we use all the tools available. And then, if there's even less overdiagnosis and overtreatment, it is highly likely, not certain, that way more men would undergo screening. And the guidelines in our country and across the world would be far more enthusiastic about screening. If you look at the number of healthy men in our country that undergo PSA screening in a meaningful way, it's really damn low. It's about 30%. And it might be appropriate because there's obviously so much controversy and debate over it. Now, I want to run through the most common counter-arguments, and I welcome any others. I collect, you know, what people disagree with, and it's important. Many say just do active surveillance. Don't bother us with this name change. But as I showed you earlier, 40% of men are still getting treated for grade group 1, and that's problematic. There are pockets in the VA, in Michigan, that have higher rates, but as a country, it's likely closer to this rate, and I see it all the time in the Midwest. This is a great paper that the group from here put out. It's not surprising, but it's still depressing. Your likelihood of doing surveillance dramatically depends on who your urologist is and which practice, and it's all over the map. It's as low as 0% to as high as about 80%. Many people say it's an education problem, not a histology problem. And all you have to do is educate clinicians and patients, and everyone would do the right thing. Well, we've known about it for a long time, and we've tried for more than 10 years, and I would argue it's had some success, but it's still kind of failing. And meanwhile, this epidemic of tens of thousands of men in our country, let alone across the world, are still getting unnecessary treatment, and it's not working as well as it should. Additionally, even if you do surveillance, there's a downstream impact of this diagnosis. Talk to men, have a heart-to-heart on their self-identity and self-image after they're diagnosed with this. In the States and in Sweden, there are studies showing an increased risk of suicide after a grade group 1 diagnosis, something that's never going to cause them a problem. And granted, it is a slight uptick, but it's measurable. And that's horrifying that there's guys literally killing themselves over something that is never going to cause them a problem. If you poll people on surveillance, these numbers have come down over the years, but there's a recent publication by a patient advocacy group that over half of men on surveillance still report cancer-related anxiety. I've had multiple patients that can't get life insurance after a diagnosis of grade group 1. And paradoxically, they actually have a better life expectancy than the average population because they've been healthy enough to screen, they've been diagnosed with something that's not going to cause problems for them, but because it's cancer, their life insurance policy cancels them. That ain't right. Speaking of impact, so he wasn't just, an artsy guy, an academic guy, an athlete, but this is him, socializing. And if you go in there somewhere, there's either a shadow or a cigarette or a vape pen in his hand. I couldn't quite tell what it was. So microscopically, it meets the definition of cancer. Yes, currently the definition, it absolutely meets the criteria. There's no basal cells, therefore it must be called, prostate cancer. But all most patients care about, they don't care about histology, genomics, molecular. You talk to them, and understandably, they care about the clinical reality of it. Is it ever going to cause me a symptom or a problem in my life? So the question comes up, why are we wedded to this strict histologic diagnosis? And there are many examples where those rules change, as I showed you in the past. Cancer existed 2,500 years ago when it was first labeled by Hippocrates. The microscope is a relatively recent invention. We're wedded to this microscopic definition, but as Otis Brawley, a very prominent medical oncologist, has said, we need a 21st century definition of cancer, not just kind of this histology H&E with an occasional stain. So why is this lack of basal cells the sine qua non of the diagnosis? And I've showed you many different examples of where we've changed names 3 times in urology and taken away the cancer label, as well as, cervix, thyroid, and others. Henson has said, the clinical pragmatism should prevail over this histologic orthodoxy. And many men, not all men, I certainly put myself in this camp. If I had grade group 1 in my prostate right now, I would not want to know about it. I do screening, but I don't want to know about my grade group 1. And for those of you that are trainees that have prostates, let's say 20% of you have grade group 1 in your prostate right now, okay? Even at a young age based on autopsy studies. I'm guessing you don't want to know about your grade group 1 at this young age. So concerns about compliance, I absolutely agree that it's a concern. And to me, this is the most valid one that, proverbially keeps me up at night. However, just for argument's sake, our practices are drowning in patients that also have undiagnosed grade group 2. Elevated PSAs, previously negative biopsies, any ASAP or high-grade PIN, and I've never heard anyone, express concern over compliance for those patients. We give them advice, we explain why, and ultimately there's a responsibility for them to decide whether to show up or not. And explain to me how grade group 1 patients are different. Their risk of having grade group 2 might be a little bit higher, but they have way more in common with these patients than uncommon. The most notable that people bring up, understandably, it's a sampling issue. There's grade group 1 on the biopsy, but pick your number, 20%, 30% have undiagnosed grade group 2. Absolutely correct. But name me any other condition where we name something a cancer based on something that wasn't sampled. I'm not aware of one, maybe there are some others. And guys who just die a natural death or of another cause, 20% of them have grade group 2 in their prostate otherwise. In every surveillance series that has superb long-term outcomes, as they're entering surveillance, 20% of guys roughly have unsampled grade group 2, and they still do phenomenally well. And if you're concerned about an individual person having grade group 1 on the biopsy, but unsampled grade group 2, we've got a lot of tools available, more than we've ever had, with biomarkers, MRI, targeted biopsies, maybe PSMA PET one day, to go find that grade group 2. Genomically, there's an overlap between grade group 1 and higher grade cancers. And that's frequently pushed out there. There's some genomic fingerprint that fits this higher grade cancer label. Absolutely. But the cool thing is when you go into the literature, before I get into the literature, if you take all grade group 1 patients, 10 to 20% will have some higher risk genomic feature by the commercially available biomarkers. And yet they still all do phenomenally well, or nearly all of them do phenomenally well. Some of these long-term surveillance series literally have a 0.1% chance of metastasis or death. But interestingly, there are benign and precancerous prostate lesions that also share molecular and genomic hallmarks with high-grade cancers. And I don't know of anyone out there shouting that we need to start calling benign and high-grade PIN cancer. So that, in my opinion, debunks that whole argument. There's a really elegantly done study that I don't even pretend to fully understand, published in Nature 2 years ago from a group from Oxford and a bunch of places in Sweden. I'm going to summarize some of it for you. Those first 3 rows, the benign clones, there's different molecular and genomic findings even in benign prostate. But if you look at clone C, there are a lot of copy number variations that are shared with high-grade prostate cancer. And again, no one is out there saying, oh my gosh, these benign prostate findings with genomic abnormalities, we should be calling them cancer. And here's a list of things that I could gather from the literature that are known to be present in high-grade prostate cancer. And guess what? X and Y in those columns are benign and high-grade PIN. The prevalence isn't as high, but they can be present in benign and high-grade PIN. This is from that same paper from Nature. This is looking at copy number gain and loss. And this is easier to understand, but you can see the gains and losses in the altered benign tissue can overlap with prostate cancer. And here's a list that Riccardo Lenni, he's a pathologist from Italy who's doing a fellowship in the States. He put together this table of looking at a lot of these abnormalities that are shared. This is a slide from Dr. Kupperberg, and it's a nice way of thinking about things. There's not some kind of, in our opinion, black-white line in the sand where something is like strictly cancer versus non-cancer. And you take a step back and from kind of, a philosophical standpoint, there's the ontology of cancer and the spectrum of what is cancer and what might cause problems versus not. And historically, we've kind of drawn the red line here. When many of us in the room were training, literally everyone that was healthy with grade group 1, even a pinhead of grade group 1, went and got treated. Thankfully, we've modified that, but all we're arguing for is maybe we should consider moving this line of what we call cancer a nudge to the right. And again, the hypothesis is public health would improve. I also hear this is a problem in the US. Don't bother us in the rest of the world with your problems. That could be true of a lot of things, but and it's true, there are many countries where the rates of surveillance for grade group 1 are, admirably greater than 90%. But guess what? From reliable sources, unpublished data looking at cancer registries and people that practice in some other places, like Germany and Japan, over 90% of people with grade group 1 still get treated. So this isn't just a problem in our country. And I would argue, regardless of where you live, removing the cancer label would be beneficial. Now, I do think it's a separate discussion for certain countries that don't have a lot of resources, don't do routine screening, don't have easy follow-up, and I have yet to, fully think that through, but I do think that's a valid point. So a year ago, we got a bunch of people in a room together, almost exactly a year ago at GU ASCO last year, and there's some familiar faces that you'll see, Dr. Braun, Dr. Kupperberg, Dr. Carroll. We purposely invited people that agreed and disagreed with us. We got people from a bunch of different backgrounds. We got people from the NCI, from the CDC, We brought people with a breast cancer background, a thyroid cancer background, and we just sat in a room for a half a day, gave short talks and had conversations about this topic. There's a paper that'll be coming out relatively soon that kind of summarizes that. So nearing the end, but ongoing efforts, and again, like I said, our group that wrote that initial paper have continued to do projects and efforts and hope to continue the conversation. Thankfully, there are other groups that are also writing about it and have projects, and we need more voices. People are sick of hearing me talk about it. I'm sick of me talking about it, but we do think it's important. And if you happen to agree, talk about it, give talks on it. And if you disagree, I would also encourage you to talk about it because it's an important conversation our community has to have. Ruth Etzioni and her CISNET group are doing some modeling on if we did a name change, what would that look like and what's the potential impact. We've written the framework of a randomized trial that we're going to pilot at our place, but hopefully do at other places where it's guys or people with before their first biopsy, they're randomized to, if it shows grade group 1, half of them are going to have the grade group 1, and half of them are going to have a different term on their path report, and we'll track everything from that point forward. The CDC recently had a request for proposals. It's $1 million grant basically on this topic, asking people to look for patient-friendly path reports, look in cancer registries, poll people with grade group 1, and try to put some more data to this question. A key feature is having ongoing discussion and debate with pathologists. They ultimately hold the keys to the kingdom of the names. I'm encouraged by what I showed you in the survey data, that about 40% of pathologists are at least willing to consider it. 4 prominent ones have at least written about it. We'll see. Things don't happen so quickly, but I'm optimistic. And then one of the things that we learned from that gathering a year ago from the thyroid folks, that's probably the most prominent example of the cancer term getting taken away. It's a type of thyroid cancer called NIFTP, non-invasive follicular thyroid cancer, and they changed it. And one of the pathologists from Pittsburgh who did it said they had worked on it for a while with clinicians, and they weren't getting much traction. And then the New York Times did a story on it, and he said that was the tipping point. So one of the things we learned is to try to push it, to the people where it matters most. So with Laura Esserman, we wrote this op-ed and pushed it out there because there are some analogies in breast cancer. There's a story coming out within the next week or two that Dr. Cooperberg and I have been involved with. There's a Wall Street Journal article on this topic that'll be coming out. And so we're hoping to just advance the conversation. And frankly, even when the reporter calls and we talk, I say, here are a bunch of people who disagree with us, and you should talk with them as well. We're not trying to be so dogmatic and just shove it down people's throat, but it is an important conversation. So lastly, in conclusion, the name of grade group 1 should reflect its benign or precancerous nature. I've never felt stronger about that, and I am very passionate about it. And there are many of us who think that individual people's health and public health would dramatically improve because of that. Now, change doesn't come easily. We all know that. There is that status quo bias, okay? And the Semmelweis phenomenon, he was lambasted and kicked out of medical societies because questioned the status quo. But as Dr. Cooperberg said at the beginning, and we could have just blind spots and biases, but we think we're on the right side of history, but time will tell.